today already about some of the evidence base, some of the gaps in that evidence base. We've heard about how that evidence is being used to develop new practice and how that practice itself is being evaluated and researched. We've had a fairly provocative provocation session, as we anticipated, which is fantastic, looking at some of the challenges that we need to be considering when we're thinking about research. But we sort of want to bring it all together in this final session by talking about, well, what are the priorities for research? As we're planning future studies, as we're looking at what researchers spend their time on, what are the things that are the most important to the development of social prescribing? So I'm delighted that we have such a fantastic panel joining this afternoon. We have Miranda Wolfer, who's Head of Mental Health with the Wellcome Trust. We have John McMahon, who's Senior Manager of Policy Research from Arts Council England. We've got Matthew Pike, who's the Programme Leader for the Healthy London Partnerships work. And we've got Duncan Tree, who's Associate Director of Policy and Partnerships for the Association of Mental Health Providers. So I'm going to start off by speaking to our speakers about some of their initial thoughts on priorities, and I'm going to ask them a few questions as well. And then in the second half of this, we're going to bring in questions from the audience too. But something we thought we'd just start off with is a bit of a sense of who we have in the room. So we're wondering, if you are someone who works actively within research or evaluation, could you raise your hand for us? Okay, and what about if you're someone who works leading or working within some kind of arts or cultural heritage organisation delivering programmes? Fantastic, and it's great to see some of the overlap in hands between people who are working on research and evaluation and on delivery as well. What about people who are working somehow within health, or within the health sector, or within aspects of commissioning? Miranda, as you know, in terms of your mental health research. So I wondered if you could just start by saying what you think some of the priorities for research within social prescribing should be.
Fantastic, thank you. Thanks for having me here today. First thing to say is I'm not head of mental health. I'm head of a mental health priority area. So there's a whole range of mental health funding across Wellcome, and that will continue. So those who are researchers, I'm going to talk about the priorities for my bit, but I want everyone to be aware that there are lots of other people funding all sorts of other research. So please keep on applying to us. We don't do that very often from funders, but we're saying please apply. So in terms of I'm really in the fortunate position of heading up a new initiative within Wellcome. We have £200 million to spend over the next 5 years on mental health research globally. So it's not just UK focused. And we are a priority area in the sense that Wellcome has chosen 10 big, or in fact 9 big knotty health problems that it sees, and mental health is one of them, where it feels just funding in the way it currently funds, which it will continue to do, is not the only way of doing things. So these priority areas are looking at new and innovative ways of taking the field forward. So I have a really lucky position of leading that particular part of the work. In order to do that, we've come up with a strategy which has now been signed off by our board, so I can now share it, and we aren't in Purda, which is amazing. So I can tell you about it. So we've got a strap line which we're aiming for and that we would work with everyone else in the world on, which is a world in which no one is held back by mental health problems. That's our vision. We absolutely won't do it alone, and we won't necessarily be the main contributor to that. There will be many people doing many things that need us to get there. Our particular focus is on the science and bringing transformative science and public engagement and cultural engagement to bear. We have 5 years of funding initially. We have a potential for another 5 years of funding, but the idea is it's a time-limited programme. In order to be sort of meaningful and have impact, we're focusing down our thinking. We're focusing on anxiety and depression. We're focusing on young people aged between 14 to 24, and we're focusing on selected geographies. And in particular, we're wanting to work both within the UK, but also within lower resource settings, particularly thinking about India currently and possibly 1 or 2 countries in Africa. So that's the way we're sort of scoping. And we have 3 work streams that we are wanting to develop. One is about building a mental health science community. Another is about exploiting the power of population level data. And another is about leveraging political, public and philanthropic resources. And underpinning that, we have sort of 4 pillars of principles of practice that we bring to bear. The first is empowerment. We think everything should be done with the voice of people with lived experience of mental health problems. We're deliberately using the term lived experience rather than service user because we're aware that the majority of people with lived experience never come anywhere near what we're currently calling services. And interestingly, I was at a conference the other day where someone said we should stop calling these services and start calling them biomedical services and be aware there are a whole range of other services that people may be in contact with or other approaches we may be doing. So one of our sort of first points is empowering multiple voices of the diversity of people who have experiences. So I can't see Debs at the moment, but just talking about that powerful experience, but also recognise that different people's experiences may be different. So what's life-saving for one person may be different from another. So I guess that's one perspective. Then our other pillars are evidence, advocacy and sustainability. I'm aware I've gone at length, so I'm just going to say one more thing, and then perhaps from questions we can look at some of those worksheets it fits. In fact, I'm going to say two more things. In terms of our understanding of what counts as an intervention, this is where I think the priority comes for social prescription. We believe you've got to move beyond thinking intervention is something that's done one-to-one in a room, and start thinking about the full range of approaches, techniques and life events that maybe change people's lives for the better, both in terms of prevention, intervention, managing ongoing difficulties and relapse prevention. So those are the four categories we're thinking in, and we want to look at the full range of things that might do that. In order to do that, we think we need to build a much wider mental health science community, which will include ranging from philosophers and English majors and historians right through to neuroscientists and mathematicians, and we need to recognise all that expertise with lived experience being at the heart. And then the second sort of big idea we need to exploit the population level data. At the moment, we have most information comes from a sliver of community. Most of it comes from weird populations, and whether people are aware of the acronym WEIRD, it's not something I made up, it comes from the literature. It stands for Western Industrialised, Educated, Rich and Developed. And within that Western Industrialised, Educated, Rich, Developed community, it's that sliver who access services, who get into the data sets, who themselves are quite a narrow grouping. So being able to look at both randomised controlled trials and cohort studies, which looks at a much wider population level, is something we're very interested in.
Fantastic, thank you. That's really interesting. And in fact, a couple of things that immediately kind of leap out from what you just said. One of the points you made was around the relevance of lots of different disciplines. And this is something we spoke about a little bit this morning, but I think it's obviously a big challenge in terms of how you bring together something that you've learned from philosophy with something from English literature, with what you've learned from, let's say, psychology. And I wonder if you have any particular thoughts or tips on how things can be done in a meaningful cross-disciplinary way for this topic.
Yes, so we have three big ideas about this, which I'm sharing here slightly nervously, because one of them is a made-up word that we're sort of floating here publicly for the first time. So I'm quite nervous to see what Andrea tweets about it and what other people think about it. So we're thinking about this term plexology. So made-up word, plex meaning to weave across, and ology nakedly to give it status. So what we want are plexologists, which are the future generation of people who are scientifically literate, but not aligned to advocating for any one perspective, that can look at the evidence that's already there, already published. They won't be doing primary research stuff, but they'll look at the published literature, they'll look at what's already there, because we think there's gold dust to be got in the existing literature that we can't see because we're in our siloed communities, waging wars with each other over issues about what, as if there's one cause or one way of seeing the world. So one of our ideas is, can we create that group? Whether we call it plexology or not in the end is up for grabs, but we want to develop that cohort of people and think about that, so that's one thing. Another thing is that we want to try and help think about what might be the core components of an effective intervention at a level of granularity that's away from a brand. So we want to move away from the idea that there are these branded things that are very complicated. In the end, we'll probably have to build them up again, but at this point, we want communities to come together to think, what are the core components? So it could be social connection, it could be tax systems, it could be chemical imbalances, it could be a range of different things. We want to bring the community together to agree what the best bets are for thinking about future research, and that's something we want to do as an exercise with the wider community. And the third is we want to agree some common metrics that are really non-burdensome and really simple, but that everyone will collect so we can start to compare across, likely to focus on functioning and the impact on people's lives, rather than anything about diagnostic or health. So those are the three ideas that we're thinking about, that we're really interested to hear people's views on.
Thank you. And in fact, that just ties in with one other thing I wanted to pick up on, which was you're talking about the idea of this sort of common metric that we can look across different studies. But you mentioned something earlier, which I think is true, which is that what's life-saving for one person is different from what's necessarily life-saving for another, and the way that manifests itself is likely to be different too. So I'm wondering, with sort of mental health research in general, how we align these issues where we want to have some kind of comparability across studies, but the fact that the types of outcomes, as we've heard a lot today, can be so different. How do we do that effectively with research?
I think it's really hard, so I'm not denying it's really hard, but I think you start with the most common and non-burdensome you can. So for me, that would be functioning coming from a health perspective, but I can see there may be others that other communities may want to get, and we need to get as much consensus as we can get on which of the top three. I think the main thing is you're never going to get everything, and I think one of the problems with our field is by trying to do everything, we do nothing.
Yeah.
So I think you just say it's going to be flawed, we'll start with 3 and we'll review in a year's time, and then we might change them. So you build in iteration from the start, and you don't assume you're going to get perfect, and you don't assume that talking about it for 2 years is going to give you a better outcome than deciding within 3 months. That's my presumptions I bring into the field.
Thank you very much. We're going to come back to ask more about your views in a moment, but I want to bring John into the conversation now, because John, I think you have a particularly fascinating role at Arts Council, and your role combines policy and research. So this really brings us to the crux here of how we do research is actually going to have some kind of impact and is likely to be changing things in the ground. And I'm wondering what your views are about particular priorities for research and social prescribing.
It's a super interesting area at the moment. I should say my contribution might be a bit more bland than it might otherwise have been, because we're in the pre-election period. I'm kind of limited on some of the kind of spicier things that I can or cannot say. Also, for those of you who don't know, the Arts Council is on the cusp of publishing a new 10-year strategy that will run from 2020 to 2030. There are still some details to be finalised, and I can't preempt every aspect of that. So, but I can give an indication of. Well, actually, a good place to start actually is a piece of work that was done about a year ago, with the specific purpose of informing the new 10-year strategy that was actually led by my colleague Richard Ings, who's over here in the archway. Richard undertook a sort of 5-year evidence snapshot, largely but not entirely focused on academic research into both arts and health and well-being, and also arts and criminal justice. And it was a good starting point because it identified for us a number of potential gaps in the evidence base at the moment that apply right across arts and health, but I think have also relevance for social prescribing. There are a few of those that are quite general in a way, so there's a real need to identify, and you spoke about this earlier as well, Daisy, to identify what are the active ingredients in interventions that really make a difference and that can be replicable across different interventions at different times by different organisations with different client groups. I think very often in the research base at the moment you have reports and inquiries that have been done with quite a narrow focus that don't necessarily give you that sort of translatability. Alongside that, there's this issue of how do we capture information that can be compelling for commissioners in order to influence and shape their practice, and I think those two challenges are strongly interlinked. There are some specific issues as well that we identified, firstly around breadth of coverage for different types of illness or health challenge. So the evidence base is pretty strong around mental health in general, with specific strength around the most commonly addressed conditions: anxiety, depression, stress as well. There are gaps around less frequently addressed, so suicidality, addiction, personality disorders, things like that. There are quite significant gaps around physical ill health, physical well-being. There are some sort of islands of really good evidence around specific things like singing for COPD or dance for Parkinson's or dance for falls prevention in the elderly, for example. But even things that you might assume there would be a really kind of common sense read across, so dance in general having the same well-being benefits that physical activity does that we know from the sports evidence base, that's kind of lacking at the moment. It's not to say that that benefit doesn't exist, it just we don't have the substantial evidence base that we need to really powerfully articulate that at the moment. From an Arts Council perspective, there are some gaps, particularly around the arts and creativity side of things. So we're really interested to know what difference do different conceptions of artistic quality make to the effectiveness of different types of intervention. We're also really interested in, relating back to the point about active ingredients earlier, what is the benefit of engendering or building creativity for the individual, both in terms of the immediate health and well-being benefit, addressing a particular condition, but for the longer-term well-being, agency, self-efficacy of that individual. Is that a good place to pause?
It is actually, and this actually brings me to a question I've wanted to ask you anyway for a while. I thought I might as well ask it in front of an audience. Something that we haven't had discussed today, but I know sometimes does get brought up, is whether the sort of instrumentalisation of arts as part of schemes like social prescribing, where we're sort of often encouraging them with quite a specific health purpose in mind, whether that in some way is at odds with the general thinking about funding great art for art's sake, or whether there's even a risk it might damage or limit the development of arts practice in the country. And I wonder whether you have any concerns about that, or whether in fact that's not seen as something that's a worry as we're trying to develop both the evidence base around this and the practice around it.
It's something that we have discussed a lot. I think people who are familiar with the work of the Arts Council will know that the kind of tagline on the 10-year strategy that we're just coming to the end of is great art for everyone, and it was never the sort of intention behind it, but it's easy to interpret that as a sort of forming high art and distributing it, and with the focus of the new 10-year strategy is going to be much more of creative potential and an entitlement to creative and cultural engagement. So that's a very different lens through which to be seeing the creative and cultural industries. But more specifically to your question, I think for a while now we've been working from a position where we see instrumentalism versus artistic quality as a sort of false dichotomy, and a perception of quality around interventions in the sort of health and well-being sphere, so we're able to understand what artistic quality that people might relate more to what goes on stage at the Royal Opera House, thinking of some big organisations. But I think probably for anybody working at this intersection, to think of many organisations that are really at the cutting edge of really strong outcomes in health and well-being, output of the highest possible quality as well. So it's definitely not an either or.
Thank you. Matthew, I'd love to bring you into the conversation now as well, and particularly ask, we've heard from John now, particularly looking at an arts perspective, but whether what John's been saying it aligns with your views on social prescribing.
Right, so maybe we could track back to the alignment to build a new organisation nationally. We have a lens of health in it of the whole neighbourhood. We're interested in all the people of all of us go and engage with this. So the key point is that, there's a cottage industry. Right now we're making the rail track, but like Buster Keaton, as we sort of go along it. And I guess my interest is how we work in a much more systematic way, in that full sense of the word. So the first thing that we're focused on doing is provide, which we're testing right now, there'll be something a lot like standard system, standards of health data, founded on some common standards which allow for interoperability and allow us to basically do things much more easily, much more cost effectively than is now the case. So that includes the ability, like the work you were describing, Daisy, earlier on, to develop a counterfactual to demonstrate impact, a synthetic control group, with now, frankly, all of the agony and open heart surgery, your standard RCT, all the descriptive analysis we're able to do to ask, okay, what works better for whom, in what context? And frankly, so they don't have to keep proving themselves. And a lot of the data is collected to develop, a whole, I'm going to be quick because you're looking at me.
No.
The fantastic Mental Health and Arts project, if you like, interventions with a capital I into local context, where very often you actually need to take those active components, to build out of existing practice, rather than seeing it as a replication effort, which is almost always really hard and costly to do. So the signatures, the attributes of success, I think is extremely important. Mental health in general, trauma, I wanted to flag. That's the area where our threadbare, overstretched mental health services are in particular. They don't have a solution other than this. As somebody here, I saw this EMDR. There are a few things, but totally on the margins of current, IACT provision. So mental health and in particular trauma, that is a major policy need right now. So that was my point 3. My point 4, I'm now tempted to call plexology. The way, no, but I don't know. The way I see this is we need data, we need insight for all sorts of different purposes, but there's what the literature, conventional literature tells us, the RCTs, the systematic reviews, which helps answer questions like what works here and therefore what might work there. There's all the different use of data we can use locally to understand patterns of demands and flows and bright spots of practice. There's design, the ethnographic insight, which above all tells us what good needs to look like. And then there's the iterative process of test and learn, which helps us discover over time what's optimal for here and now. So there's something about this synthesis. There's something about this sort of event leading to all sorts of different professions coming together to actually build out the foundations of knowledge. So I don't know how you describe that as a priority, but I guess it's something about alignment. It's just really, really visionary alignment of how we build useful knowledge together.
Thank you very much. I think it definitely speaks to the vibe that we have from today, including the diversity that we have in people who are attending this conference. That I think the concept of plexology and the concept of bringing together people from lots of different disciplines to look at this very complex issue has to be the way forwards. I'd love just to pick up on the sort of concept of hierarchies within evidence base as well, because you've mentioned about RCTs, but the challenges in terms of the length of time it takes and the potentials of things like simulation approaches that I spoke about earlier this morning with cohort and big data. But do you think that there is, within mental health, do you think that there is a worry that there is not going to be enough of the gold standard, traditionally accepted gold standard evidence for it to be taken seriously by the people who are most cynical about this topic? Or do you think that's a worry that we shouldn't be focusing on as much at the moment, and instead we should be pushing forward with the types of priorities we've already been speaking about so far in this session, that have spoken more about things like population level and active ingredients, etc.?
So, it's rather like our provocations earlier. It requires a really nuanced approach, a nuanced answer. Ultimately, people like Her Majesty's Treasury, of course, do want the gold standard evidence. And I've advised most government departments in my time, many of them, of course, are after RCTs, because that's, frankly, most of what they understand evidence to be, if I'm sort of a bit slightly rude about it. More important than that is proving to local stakeholders that there is something of value and of quality and of use here. And that looks a bit different. I should have said, by the way, I can't say too much about this, we are building a model of co-funding locally. Yeah, we have figured out a way, we think, for Job Centre Plus and CCGs and local authorities and employers and personal health budgets to come together, very much as Craig described, with a tariff type system. It's not quite a tariff. So for that to work, we above all need to demonstrate impact on NHS use. We have to do that, so we can do that. We can use GP data, we can track welfare spend, we can track employment status and other things. That's more pragmatic. But of course, this is my point about the ability to build, not making it up, but building some control groups which are sufficiently powered, have sufficient robustness for any clinician locally to say, yes, this is good enough for me, but it doesn't try and do things like randomise at point of access or present the capacity and resources of most local areas. So, does that make sense?
It does, brilliant, thank you. Duncan, I'd love to get your thoughts on this as well, because I think your role sounds absolutely fascinating in that you're working with mental health organisations at national, regional and local levels, and I'm wondering whether this particular lens that you have means that you're seeing any different priorities from what we've already heard of.
So I did get the question, but I don't know if I answered it on the way up. And so I had a sort of script in response to the... if I stick to the script, it might be safer for me, but it also might be less fun for you. So if you want to get a bit messy, we'll do a bit of script and otherwise in responding to your question there, David. So the association represents, is a national representative body in England and Wales for mental health providers. So we've got everyone from Mind, local Mind organisations, Rethink. We work in partnership with the Centre for Mental Health, Turning Point, some big regional organisations with local footprints like Imagine Independence in Liverpool, and a charity that I'm involved with in St Leonard's on Sea. We had our AGM yesterday, Seaview, pretty small mental health, well-being, homelessness, addiction charity. So all the issues that have surfaced today, particularly around trauma, were very prominent in some of our service user engagement yesterday. But we do arts engagement and that sort of thing. That's usually manifests itself in some really good stuff around user-led photography, personal stories, but also quiet, basic stuff. Don't call it social prescribing, just call it stuff that people want to do and that works for them. Anyway, so the association's got a commitment to support the drive to personalised care planning, personalised outcomes for people with severe and enduring mental health issues, and indeed people in touch with the system or at risk of poor mental health. So we work, our members are trying to, we're working in partnership with our members to try and secure coordinated planning and provision. We champion services that provide effective whole person care. Whole person care, the narrative around person and citizenship is really important, I think, when we're talking about social prescribing. The very term has, of course, clinical, medical overtones. And so we work, as I said, with colleagues at the Centre for Mental Health, Public Health England, NHS England, and ADAS, the Association of Directors of Adult Social Services, to advance those objectives. We're an active member of the association's mental health policy group. So I think it's really important that we recognise that the voluntary and community sector is, in terms of mental health provision, is a key part of our local mental health and wellbeing services. It's not just the NHS, and that's everything from IAPT to more intensive psychiatric supports and interventions. And the knowledge and I guess the experience of VCSE organisations, and particularly those organisations who are more likely to work with people who don't have formal contact with the system, and for whose engagement with the VCSE can often be critical in enabling them to access the sort of services that they wouldn't access otherwise as a result of social economic disadvantage, material exclusion. They have a great lens, I think, in terms of what's important in terms of a modern, personalised, I won't say a mental health system based on a biopsychosocial model, because I prefer social, but I think it's critical that that lens that the VCSE provides is sort of informs both policy, best practice policy, and what we call commissioning, but in reality, most of us know is most commissioning in a lot of areas is really procurement, because real commissioning is informed by what people say they want. The stuff that say they need, that keeps them well beyond the clinical. So we've got some specific areas of interest at the moment around crisis care and improvements and in responding to mental health crisis, voluntary and community sector initiatives in criminal justice and housing. You'll know about the interface between mental health issues and the criminal justice system. 90% of people in the criminal justice system have got a mental health issue. The majority of those people weren't on the radar of services when they went into the criminal justice system. If they had been, they wouldn't have ended up in the criminal justice system. Shortly. And we're going to be serving some of our members in terms of their experience and engagement and understanding of social prescribing. Because, of course, social prescribing describes a process, a range of referrals that for many people have existed for a long time in lots of places and lots of communities. It'll be a way of describing activities that are already concurrent. So I think when it comes to what we need to think about in terms of social prescribing for mental health and well-being, and of course, engagement in arts, leisure, and other sort of activities will run alongside that. Things like, how do you complement and direct tailored support for individuals with a focus on prevention? How do you work to challenge the contextual factors that often give rise to mental health issues and needs? What's the relationship, for example, as I've mentioned, between someone's their housing needs, their poverty, their family life, their work and employment, about how you support existing capacity in all sectors. We've touched on this already. Where's the investment going? Around, where is the prescription? It's all right having a social prescribing conversation, but what are you referring to? What are you referring to people to? Lord Victor Abdawali talks about, I've heard colleagues refer to his notion of actually the negative transfer value of a social prescribing conversation, where someone is referred to another referral point and then another referral point. What is the outcome of that referral conversation? Evidence and data. What is it telling us about people's needs and preferences? Are we collecting data locally? Is data being collected on the back of those social prescribing conversations? Some of the discussions that we're having, people that lead care and support services in local communities, are telling us that their data is just suggesting that the headline demands from those social prescribing conversations are about debt, welfare rights and housing advice. So if that's what's happening as a result of those conversations, then that's where our commissioning intentions should be framed. That's where the investment should be going. And of course, people's right to access housing advice isn't a voluntary and community sector sort of pejorative. It's actually something that local authorities are responsible for under the homelessness and housing duties. So we need to be thinking about monitoring and evaluation. We need to be thinking about things like equality proofing, local approaches to ensure they don't widen the health inequalities gaps further. The biggest consumers of the welfare state post-1945 and the voluntary community sector have been the middle classes. They are the biggest beneficiaries of what we have to offer, what the state has to offer of access to arts, leisure, recreation and other services. 35 quid to see a gig at the Dome in Brighton. Black and minority ethnic issues continually on the agenda, underlined by the very, very relatively low rates of registration, voter registration for the forthcoming general election. We see this reflected. If that's a barometer of lack of citizen engagement, a lack of active citizenship, a lack of people being included not only in the formal democratic process, but also accessing other opportunities for engagement, then I think we need to understand that meaningfully. And the other access issues, of course, are around things like location, the urban-rural bias. When people talk about the challenges of delivering services in local communities, what comes up again and again? What's the biggest issue that comes up time immemorial? Transport. Right. What use is a free bus pass in parts of rural Wales where there aren't any buses? So, and supply side issues I've already touched on. If commissioning is real, then it should be NHS England and not the prescription. Now, the investment by NHS England is huge, so we're behind it in that respect. What is the offer for people with severe and enduring mental health issues who have more complex needs? Colleagues at the National Development Team for Inclusion, brilliant work they've been doing in Hackney, or a treat my mate well, giving everything else that's going on in my life. It's not an intervention with Bob. He doesn't see it as an intervention. So, as a provocation, are we prescribing art when what people really want is something that addresses poverty and exclusion, benefits and debt? And how can people do this for themselves? It's, as per me and Bob, as per, my mates that hook me up and know when to rope me into the pub on a Friday because actually I haven't made contact with them during the week. So, is social prescribing a red herring? And finally, on my way up, there's another big conference going on today in Bournemouth where the directors of children's and adult services are gathering. Let's not forget local government, let's not forget Toga Place, let's not forget Place here. So Rachel Wardle, who's the Director of Children's Services at Merton, said today, and this is a bit of a dig at the innovation sort of army here, we should be cautious against using the language of savings to justify innovation. Sometimes it is just the right thing to do. Thank you very much.
Thank you. Thank you very much. I think this has raised, from all of these discussions, a whole long list of priorities for research. So I fear it's not narrowed down massively. We've probably blown things wide open with more ideas. We've covered things that have addressed major issues in mental health, like prevention, or things like crisis as well, mental illness, We've also been covering aspects that are much more around the types of data, like looking at real-world data and the real-time evaluation of programmes. We've also been mentioning some of the active ingredients and understanding more about what it is about the arts that might be offering something, as well as looking at the issues of implementation, whether that's the direct implementation of social prescribing, or looking at things like geographical or individual factors affecting access. But I just want to first of all ask if there's any other comments from the panel, having heard one another's contributions that people want to raise. Yes, John?
A couple of very quick ones. It's easy for us to kind of presume that everybody else has the kind of contextual kind of background knowledge that we have, and I think probably shouldn't presume that. There is a cross-governmental working group, a task group for social prescribing that Matthew and I both sit on, that includes DWP, Department for Transport, Local Government Association, many of the national lottery distributors, all of the sort of central government departments. So there is that attempt to think about the sort of broad spectrum of issues related to social prescribing. Around local government in general, the LGA are about to publish a suite of resources around social prescribing for elected members and for council officers. There's going to be an LGA-led conference on social prescribing in April, and we've fed quite strongly into all of that. I think a number of other partners across the kind of cross-governmental working group have. On the local government side as well, it's no secret, and I don't think it's kind of politically controversial to say, local government has experienced a contraction over the last 10 years. So, traditionally, local authority public health might have been one of the areas that you would have looked to resource the kind of activities that we're talking about, social prescribing. More challenging in the present context. However, it's quite interesting, we don't really talk very much about the local government influence over clinical commission groups through health and wellbeing boards, which are generally quite sort of politically composed in terms of councillor representation and an opportunity to influence thinking at local government level that can flow through to NHS commissioning, NHS purchasing.
Well, I completely agree with what you said, and I think that wider context obviously has to inform what we're thinking about in terms of priorities. But I'd quite like to get your thoughts on this, Miranda, and that having just gone through a process of defining priorities within a priority area, what lessons you have in terms of how you, once you put a long list of priorities, how you actually prioritise within the priorities, so to speak.
So I have a really strong belief you have to start by saying what you're not going to do. It's really easy to just add to the list and say, what about this and what about this? So I think being really clear what you're not going to do and know that nothing's going to be perfect. So, I could give long arguments of why we chose the exact priorities, but I would be equally happy to stand up here and justify a whole other set of priorities. It's just that you've got to prioritise something, you've got to focus somewhere. So in a way, just start somewhere and don't spend too long trying to find consensus on the priorities, because you've just got to prioritise somewhere. Mm-hmm. Can I take another provocative stance, so I've got the floor, in relation to you saying, your walk with Bob is not an intervention? My worry is, I can see why you say that, and I can understand where you're coming from on that. My worry is that by not seeing it as an intervention, we take it away from science, and we reify the interventions that are as though they are something very special, and that all these other things are somehow not interesting. So traditionally what's happened in science, and Daisy asked earlier about my own research background, I went on a bit of a journey myself last year when I did a systematic review looking at interventions that didn't involve a professional for depression and anxiety for young people. And I was absolutely stunned to find there were over 100 of these different interventions that someone had suggested. It wasn't just social prescribing, a whole lot of interventions, pets, all sorts of things, of which it was a tiny handful that had ever been studied. And what I realised when we talked with colleagues about this is that we as a professional group have seen anything that didn't involve professional spontaneous remission. That's the term that's used. It just happens. People get better. But actually what that's meant is we've never looked at why they get better and the different trajectories people have taken for that. Some of whom may have used art, some of whom may have used their walks with Bob, some of whom it may have been a relationship. And until we apply the same rigour and scientific thinking to those things as we do to the other interventions, then I think we are in danger of assuming that there's this distinction that I'm not sure there is. Now, it doesn't mean we have to prescribe them all. So I can also see that we don't want to medicalise everything. But I think there is a tension here about having the same scientific rigour to the whole range of humans. And I think in a way that's the amazing thing about what you and others are doing, is you're bringing that scientific rigour, but not over-medicalising what it is.
So he is called Bob, he's a social worker, he's not on Twitter, but I bet his ears are burning. It's an interesting conundrum, isn't it, that we need science to evaluate the impact of art. I'm really... let me talk about public mental health and I'll come back to that quickly. I think there's a really interesting and energised and modern public health movement that is absolutely getting behind the idea of public mental health. They won't remind me, I can mention their names even though it isn't Purda. So people like Greg Fell in Sheffield, Lisa McNally in Sandwell, Jim McManus in Hertfordshire, who absolutely get seeing health and wellbeing through a public mental health lens. And actually many of those people are seeing and framing their local strategic engagement in a way that old directors of social services, post-BBOM, CBOM, social services used to see the world. Through seeing the value of mental health through a prevention lens, seeing the whole system, seeing, yes, it is about actually scientific intervention, but it's also about understanding the social and other or commercial determinants of health and well-being. You know, I'm fascinated by the impact of cold water swimming and sea swimming. You know, I've got into it quite a lot over the last 2 years as a way of improving my mental health and well-being. Went to an absolutely brilliant lecture by a guy who is an anaesthetist who's co-authored papers on the effect of cold water immersion on the brain and depression, etc., etc. And he couldn't answer the question, as a scientist, why we feel better just looking at the sea once we've come out. And he said, I can't answer that. There is no evidence. Just take it.
Would you like to come in on that?
I was going to respond to that one. I mean, just in terms of priorities in general, I mean, you know, one prioritises around effort and return, you know, and there are some things which are, I think, low effort and very high return. I've spoken to this about data. I think that's a no-brainer. I actually think it's really doable, you know. So that, for me, is, I feel doubly sure that's something we should collectively get involved in. Just bear with me. We are working on co-funding models, and as with all of this, really eager to speak to people after around that. That's harder to do, and it requires the first thing, by the way, to be in place, but it's really high return. The thing I wanted to speak to was leadership and culture change. You know, that is the bit that's really hard. You know, it's really hard and will potentially wreck everything. My formative experience, my first job, I ran the thing called the Paul Helen Foundation. We backed a thing called Reading Recovery, one of the gold-plated evidence interventions ever developed for reading, and it went in and out of fashion over several changes of political command. A few years ago, I worked with Graham Allen to set a thing called the Early Intervention Foundation, and again, we went to directors of children's services, and they said, we don't know how the hell to do this in a local context. So those are my everything else, you know, for breakfast. So how to haven't spoken about, but it could wreck everything, or enable everything.
Miranda, you want to
I'm happy to wait for questions.
Analyse the impact of art. That was my big question all the way through. So do we? But is it possible to really distinctly separate science from art now that we have used it to analyse its impact? And is it true that we have to use science to engage with art in this way? Can we use art without science?
Miranda, I wonder if I can bring you in on this, because I know Wellcome is an organisation that supports art and science and sees the value of bringing them together.
So I would say that by science, I mean by science rigour. So I think there is rigorous arts practice here as well. So for me, and I know our director also believes that they're trying to extend the concept of what we mean by science away from an idea that it's the biomedical and to a whole lot of other rigorous disciplines. So to me, yes, you need that rigour. So I think that, and you can find that lack of rigour in something that's technical science and something that's technical arts. I suppose for me that is a mindset that doesn't say I'm going to prove something I already believe and I'm going to go out and find the evidence to support that. It's a mindset that says I'm going to go and explore this thing in order to understand it better. And if you're bringing that rigorous mindset, whether you're using an arts methodology or a science methodology, for me that is a scientific approach. And I think going back to the point about just as we need science to understand the arts, we also need the arts to be part of the science community, to think about what we're doing. But I think that issue about rigour and thinking about things that will challenge your own beliefs is really important.
I'm going to take one more question as well. Yes.
I think following on, sorry. Hi, Karen McGranahan from Goldsmiths. I think following on from that point is that we're not really using science to judge the art. We're using science to judge the impact that it has on the person's well-being, and that is quite different, I think.
And just a plug for Goldsmiths. We did some work, but colleagues did some work with Goldsmiths, some of the students who were tasked to do a project to look at how you might measure mental health using their arts thoughts. And all I can say is sitting there, it was one of my first things I went to when I was first imposed. Their thinking about it was as sophisticated as some of the psychometricians that I worked with for the last 10 years. And I thought it was really, if we could get that sort of sophisticated thinking, we might end up with tools that actually measure what we're interested in, rather than sort of, scales of 0 to 10 and please tick here. So I think there is a real opportunity here to bring that creativity, but as you say, you've got to bring the rigour to the evaluation.
One of my concerns is that, why the compulsion? Why the compulsion? And actually, if we take it back, actually, the compulsion is on.
To the nails, can we make sure that we do no harm?
Thank you very much. I'm aware that we've deliberately built in time for people to be able to continue discussions over more tea and coffee downstairs. So what I'm going to ask now is just all of our panellists, having had this discussion and having also heard different things across the day, if you had one take-home message for researchers or for those who are working within research and evaluation about take this forwards in a productive way or a way that's going to impact on policy or practice, if you'd like to share.
Try and build in ways to be self-critical. So whether that means collaboration with people that don't agree with you, trying to find people who see the world differently. It's really hard to do. I hate it. But it's really...
Sorry, I didn't catch your name, but you spoke to what are the purposes of evidence in its broadest sense. And do no harm is a jolly good place to start. Support people better is possibly next in the line. I think it's really important that commissioning, and that bit is down the line. Otherwise, we are into cynicism and a corruption of the integrity of what we are talking about. So there's something about being clear what the most important use is of evidence.
Thank you. It's very helpful to think about that in terms of the use, what's going to be happening with it. John, are you happy to?
Yeah, absolutely. I think it's really clear that we've got, an evidence base between, a very broad spectrum from academic and healthcare-led research at one end, RCTs highly rigorous, to the very variable sort of spot evaluations of projects and activities done at community level at the other end of the spectrum. I think we're in a position now where we have quite an interesting infrastructure that could be deployed, a lot of you know. We have the new National Centre for Canterbury Christchurch. How do we the knowledge base that we have through those assets that we have available? I think that should be quite straightforward. Just and Daisy, you're amazing. Sort of at the centre of the nexus, have a clear narrative that we can use to talk to stories.
Last word, Duncan.
Is what people. Alan Johnson's call for participatory arts to be part of mainstream health and social care. We need to avoid wheel reinvention. And finally, return to my earlier theme, is actually we need to really understand and look at this through the lens of inequality and access. And if we don't do that, then we fail the people who stand most to benefit from what clinicians call an intervention, but what they might call just doing stuff that matters to them.
Thank you very much. I'd like to thank all of our speakers very, very gratefully for contributing to this session. So thank you. So